Hi everybody, I'm Enrica Orsini, I'm the scientific lead of EHA Education.
I'm Paolo Ghia, I'm professor of medical oncology at Università Vita Salute San Raffaele Milano, where I'm directing the CLL program.
Welcome, we are here today to speak about treatment in CLL. Paolo, the treatment landscape in CLL is becoming quite crowded and it's a little difficult for people that is not involved in this disease to understand new things. So can you just give us a little summarize of what is available today for CLL patients? Is immunochemotherapy still the mainstay, or there are new drugs?
No, indeed, it's rather complicated. I understand that if you are not really a CLL expert, maybe it can get confusing. I have to say that nowadays chemoimmunotherapy is probably disappearing in the treatment landscape of CLL, at least if there is enough, if there is access, if the new drugs are available, as it happens in most of our European countries. But of course the world is much larger, much bigger, so in many countries still, of course, there is the need of using immunochemotherapy. But just beside immunochemotherapy, I think that we have now many other drugs, chemo-free drugs, and in particular two main pillars. One are the BTK inhibitors and the other are the BCL2 inhibitors. At the moment we have only one, venetoclax, but there are many others that are indeed in phase 1, tested in phase 1 studies, so we expect that in the next few months or years we will have again many other molecules in that context. For BTK inhibitors, we are now at the third generation. So we have ibrutinib first generation, acalabrutinib, zanubrutinib, an evolution, better drugs in terms of tolerability, maybe even in terms of efficacy. We will see at ASH the late-breaking abstract on zanubrutinib with the 2 years outcome data. And then there is the third generation, pirtobrutinib, nentabrutinib, and many others that are targeting the BTK, the mutated form of the BTK, so they can be used in patients who become refractory to the first and second generation BTK inhibitors.
So at the moment, how many of these drugs are approved?
Approved are probably ibrutinib, acalabrutinib in most countries, and zanubrutinib is in between. It's not yet approved for CLL in many countries, but it's already approved for mantle cell, for Waldenstrom, and it might be approved very soon for CLL. Pirtobrutinib might be available for compassionate use, and we expect both pirtobrutinib and nentabrutinib maybe in the next couple of years to be approved.
For which kind of patient?
They will start with a relapsed refractory patient with CLL, and then probably moving also to first line, but that's again long-term.
So today, no, this is just really something to know. For as of today, which BTK inhibitors can be used in first line?
Yeah, first line we have ibrutinib and acalabrutinib,
okay,
plus or minus obinutuzumab, depending again on the reimbursability.
You were speaking also a little bit about the side effects of these drugs. There are specific side effects that...
Yes, indeed, that's the main issue probably. All the drugs that we have are very effective. We are prolonging survival of our patients, and indeed we are going to present here at ASH also an abstract showing that the patient, especially elderly patients, treated with the novel therapies have a life expectation that is equal to people who are not affected by the disease. Having said that, there are side effects, typical side effects of the what we consider the BTK inhibitor class. But then every new inhibitor is claiming that it's not showing the same adverse events. We have to see, of course, with longer follow-up. We are talking about, in particular, cardiovascular toxicity, so the risk of cardiac arrhythmias, hypertension, and also the risk of bleeding, in particular major bleeding, which is very rare, but of course it can be it can have major consequences. For this reason, the field evolved towards not anymore continuous treatment, which is typical of BTK inhibitors, but with fixed duration treatment. And that has always venetoclax, the BCL2 inhibitor, as the central pillar of the treatment. So either in combination with antibodies, anti-CD20 antibodies like obinutuzumab in first line, or rituximab in second line, for 1 year or 2 years, depending if it is first line or relapse refractory setting. But also now we have approved, it is approved, the combination between BCL2 inhibitor venetoclax and BTK inhibitor ibrutinib for 1 year in first line.
Thank you. In the paper we are trying to discuss today, there are reported the long-term results of the ASCEND trial. Do you want to briefly summarize?
Yes, that's a paper that has been published on Hemasphere, the EHA journal, and it is the final analysis actually of the ASCEND study, which we already published with a follow-up of 16 months. And it is a randomized studies between acalabrutinib, so second generation BTK inhibitors, versus physician choice of idelalisib plus rituximab or bendamustine plus rituximab, and this is in the relapse refractory setting of patients with CLL. And as I said, this is the final analysis at roughly 4 years of follow-up. We already published the data at 16 months, so roughly 1.5 years. And of course, with the longer follow-up, we confirm same efficacy and same tolerability of the drug. And in particular, because as we know, idelalisib, which was one of the two comparators, is not so well tolerated, so most patients cannot remain on the drug for more than 18-24 months. So patients progress earlier, they have toxicities, so that we know indeed that the BTK inhibitors became somehow one of the most common treatment for CLL, while instead the PI3 kinase delta or PI3 kinase in general inhibitors are finding difficulties in being used for patients with CLL.
And something about high-risk CLL patients as the one is, with TP53 mutation or deletion 17. There is something for them?
Yes, indeed. I think that what we learn is that we can use exactly the same drugs, exactly the same combination in patients with P53 aberrations. As you said, the deletion 17p or mutation in the P53 gene. For the simple reason that these were high-risk patients because they did not respond to the only therapy that we had available in the past, so immunochemotherapy. For that reason, the patients who were progressing with P53 aberration, they were simply not responding and therefore not having much of a lifespan in front of them. Nowadays, with the novel therapies who are not using or relying on the P53 activation to kill the cells, then the response is very similar to all other patients. So definitely
think that in the future there could be not any more high-risk patients?
In fact, that's what we are discussing. Nowadays, patients with P53 aberration are not anymore to be considered high-risk patients, if not for the simple reason that they have to avoid immunochemotherapy. For the treatment, we are still discussing. The data is probably not mature. Definitely the continuous inhibition with BTK, continuous inhibition of BTK is probably at the moment the treatment that can give the longest responses, the most durable responses in our patients, very similar to all other patients. As for all the other patients, we would like to get to a fixed duration treatment, so in order not to expose the patient for a long time to the drug. The fixed duration treatment probably are less effective in this particular population, so they tend to relapse earlier, as shown with the combination between venetoclax and obinutuzumab. Still, they relapse after 4 years, 49 months of PFS, median PFS, with only 1 year of treatment, which is a good result. All the other patients, they have a median PFS which is much longer. Even not yet reached, for example, for mutated patients with mutated immunoglobulin genes. So we have still work to do. The combination between ibrutinib and venetoclax is also more effective, but still the patient with P53 relapse earlier than the other patient. roughly 82% at 3 years of PFS, while the other patients have 90%, so still very high, but still there is a difference. So we can improve, but definitely they have a very nice and longer life expectation at the moment.
Good. And to finish, how do you envision the future treatment landscape for CLL? Which class of drugs you think there will be the mainstay of treatment in the next years?
Yeah, in the future we are exploring a number of new drugs, but I have to say that somehow we are becoming afraid of leaving what we have, meaning that the BTK inhibitors and the BCL2 inhibitors are really revolutionized the treatment. They are very effective, and at the moment there is nothing that really seems able to overrun these drugs. So what we are thinking is mainly to create a new combination using these two drugs as the backbone somehow of the treatment. So of course there are bispecific, CAR T cells, many other drugs, but at the moment there is nobody that seems to be able to really take over these two drugs. The future will be maybe not fixed duration, but time-limited treatment, meaning that probably using the MRD, the detection of minimal residual disease, we might modulate the length of the treatment depending on the response in every single patient.
Thank you very much.
Thank you. Thank you for having me here.